Hi everyone, this is Dr. Ahmed ضياء Abdul Wahab and this is Highlights in Radiology. بالبداية أريد أنوه أن هاي الحلقة برعاية مركز القلعة للاشعة التشخيصية، وهو مركز متكامل يحتوي على كل أنواع فحوصات الأشعة من الرنين المغناطيسي والمفراس الحلزوني والسونار والدوبلر الملون والأشعة العادية والملونة وفحوص الثدي الماموغرام وفحص هشاشة العظام كذلك، بالإضافة إلى مختبر مجهز بأحدث الأجهزة وكافة الفحوصات المختبرية. بالإضافة إلى ذلك يحتوي المركز على مركز لمعالجة الأورام السرطانية ومركز لعلاج الأمراض العظام والكسور، بالإضافة إلى مركز للعلاج الطبيعي مجهز بأحدث الأجهزة. مركز القلعة للاشعة التشخيصية في اربيل، راح تلاقون كل المعلومات موجودة في وصف الفيديو. Today's episode is about a very interesting subject. Please keep watching and don't forget our competition. If we cross the 10K barriers by the 30th of November, you'll get a free CT mini series, and I will not tell you the number of subscribers now. Just keep watching, keep sharing, keep subscribing, and I'll see you at the end of the month with the result. So let's start. Okay, so today's topic will be about the well-defined infectious lesions of the bone. If we have infectious lesions of the bone and they are well defined, what's the differential diagnosis can be? So the first differential diagnosis of this, and the most common, is Brody's abscess. Brody's abscess is an abscess that happens within the bone. Usually it's due to Staph aureus infection, and it's related to a focus of subacute or kind of chronic pyogenic osteomyelitis. So it is basically a well-defined intraosseous abscess of pyogenic osteomyelitis. And the lytic lesions, usually they have an oval configuration like that here, and they are oriented along the long axis of the bone. They love the area of the metaphysis or metadiaphysis. They have a sclerotic rim, as you can see here, and usually they are directed along the long axis of the bone, and sometimes they open into the growth plate. So this is what we call Brody's abscess. Another example of a Brody's abscess, you can see here, it's in the metaphysis and it has some cortical destruction here and extends into the growth plate, into the articular surface. Typical Brody's abscess. Another example, you can see it here on the X-ray. It's oriented along the long axis of the bone, has a sclerotic margin, and you can see here on the MRI it's fluid content with marked surrounding edema, confirming this is an inflammatory or infectious bone lesion of chronic pyogenic osteomyelitis, also known as Brody's abscess. The other possibility is fungal diseases. Fungal diseases like blastomycosis, mycetoma, histoplasmosis, etc. Fortunately, nowadays they are very rare because they need immune-compromised patients with long exposure and things like that. For example, you can see in this case you have a lytic lesion, multiple, in fact, lytic lesions. On the CT scan, you can obviously see the areas of bony resorption, let's say, and on the MRI, the whole thing is inflamed, confirming, and this was a case of fungal infection. Another case of fungal infection, you can see it's well defined, it's lytic, it has its destructive pattern, the surrounding soft tissues are involved and inflamed, and it looks like an osteomyelitis kind of, but with the cystic appearance or well-defined lesions of the bone. It can be also multiple, like in this case you can see there are innumerable foci of involvement of the bones of the ankle joint, the calcaneus and the talus and other bones. Okay, the other possibility is a hydatid disease or hydatid cyst. Hydatid cyst, as you know, it's an echinococcal infection. It's a parasitic infection. In the bone, it has basically the same appearance of the lesion elsewhere. That's a cyst, uni or multilocular. You can see daughter cyst inside, and on the MRI it behaves just like any other cyst. That's hypointense on T1 and hyperintense on T2 weighted images. You can see the water lily sign, which you have to Google it if you don't know it. I will not explain it here. And always the capsule or the peripheral aspect of the cyst takes contrast because it's a fibrotic capsule and it belongs to the human body, not to the parasite. For example, you can see here this bone is involved by a multiple cystic lesions causing some expansion of the bone, and these were hydatid cysts. On the CT scan, you can see the pelvic, the bony pelvis, and the proximal femur are involved by a lytic process, let's say, with multiple cyst-like appearances, even causing some pathological fracture. Here, this was a case of extensive hydatid disease, and you can see on this X-ray there are multiple cysts within the bone, and these were also hydatid cysts. Another example, you can see extensive marked involvement of the femur by multiple cystic lesions of hydatid disease. The other possibility, which fortunately it's much rare nowadays, is leprosy, or what's called lepromas. There are multiple lepromas affecting the bone. There will be absorption of the bone, which manifests as decrease in the length of the bone and the width of the bone with tapered appearance. They call it the licked candy stick. It's just like a candy stick that has been licked. And when it's complicated by microtrauma or secondary infection, the digits might get resorbed. Okay, so for example, you can see in this image the digits are resorbed, okay, due to lepromas or leprosy. Again, you can see here this digit has a licked candy stick appearance, like a candy stick with someone licked it, and there is a cystic lesion, or what appears like a cystic lesion here, but it's not a cystic lesion, it's just lepromas. Again, you can see here this appearance here, and here due to bone involvement, which was a case of leprosy. The other possibility is spina ventosa. Spina ventosa is basically TB dactylitis, TB of the fingers. So it's more commonly affecting the proximal phalanx of the index and middle fingers, and there is diaphyseal expansion with, uncommonly, there is a periosteal reaction. Periosteal reaction is not very common in spina ventosa cases, and usually they heal by sclerosis, which happens gradually. For example, you can see here there is a destruction of this bone here and this bone here, and this was a case of spina ventosa or TB dactylitis. Another example, you can see this, the metacarpal bone is involved by spina ventosa, and you can see here also in the CT scan the bone is destroyed and affected by something, which was a case of TB dactylitis or spina ventosa. It can take this appearance also, a little bit aggressive pattern of bone involvement and extension into the adjacent soft tissues. The other cause is a tuberculosis due to atypical mycobacterial infection. So the difference between TB and spina ventosa is, when we talk about tuberculosis, we are talking about the atypical mycobacterial infection, and it can happen in the spine, hip, knee, foot, wrist, hand, shoulder, basically anywhere. And diaphyseal foci, they happen in the diaphyses, and usually it's spread by hematogenous pathway. So you can see here, for example, these both hands are involved by multiple well-defined lesions of TB, of tuberculomas, multiple bone involvement in both hands of tuberculomas. In the wrist, you can see the humerus is involved, the ulna is involved, the radius is involved by multiple cystic lesions. In the CT scan, you can also appreciate the focus of infection with surrounding sclerosis. As we said, the healing occurs gradually in these cases. Also in the ankle joint, you can see the involvement of the dome of the talus bone. And another example, destruction with multiple cystic lesions involving all visualized bones. So this was our presentation for today. I will not take any more of your time. Just want to remind you, keep subscribing, keep sharing, and I will not tell you the number of our subscribers till the end of the till the end of November. That's the 30th of November. And if we pass the 10K barrier, you will have a mini series about the brain CT scan and how to do it and how to read it. Keep watching, keep waiting for us, and keep supporting us, and we will work together to get the best results possible. This was Dr. Ahmed Dia Abdul Wahab, and this is Highlights in Radiology. See you next week, next Friday at 5 p.m. Bye-bye.